to thank you for putting your microphone on mute when the presentation begins. Please try to attend and be engaged in the session. And also, we do ask that you submit an evaluation form, which I'll be giving that information again in the chat box at the end of the session. So this is the South Texas Regional Family Medicine Grand Rounds, and this is with our partner, the South Central AHEC, following our department's mission statement to invent a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. So for those of you who want to claim the CME credit, please make sure that you go and register, and then also you can visit the CME website. You can also get a copy of your transcript there, but the email and phone number are available if you have any questions. If you would like to claim credit through AAFP as well, you can go ahead and contact them. The information is there, the phone number and the email are there. And so today we have Dr. Seena Jose. She's going to present to us the top poems of 2019. I am not probably going to be able to pronounce some of this, but I'll give it a try. Among 4 oral anticoagulants, apixaban had the lowest rate of upper gastrointestinal tract bleeding, which was further reduced by cotherapy with a PPI. So I will let Dr. Jose take it away. She was mentored by Dr. Montañez Villacampa. So I'll let her take it away.
Good afternoon, everyone. I can't see y'all, but feel free to enter questions or unmute your microphone if you have any questions as we go. I'd prefer it to be a more open discussion, so I'm not just talking for half an hour, but I will go ahead and get started. So Dr. Montañez and I have no relevant financial interests with this study or this research. I'll be talking about a 2018 JAMA publication that discussed upper gastrointestinal bleeding and how that related to anticoagulation therapy. Of course, proton pump inhibitor cotherapy was the target of analysis and how that affects people on anticoagulation. I'll talk about some opposing corroborating factors and then how that applies to our clinical practice. So we already read the name of the study. It was produced by group Ray et al. And was highlighted by our American Family Physician Poems 2019. And the clinical question that they addressed was, are anticoagulant drug choice and proton pump inhibitor cotherapy associated with risk of upper gastrointestinal tract bleeding in Medicare beneficiaries? So the design of the study was a retrospective cohort study. Does anyone want to jump in and remind us all what retrospective cohort study means? The microphone or the message type in chat is fine. Anyone? Okay, I'll take that as a sign for me to answer. So we go back to our step 1 studies. Cohort studies are ones that we are trying to look at how exposure or lack of exposure of a certain drug or other factor affects the incidence of the disease. And so the type of study this was looking at exposure versus non-exposure of PPIs. And it was retrospective because it went and looked at all these Medicare beneficiaries, tons of them in the United States, 1,643,123 patients. And they went from analyzing from 2011 to 2015. So almost a 4-year span. And the major outcomes that they looked at was hospitalization for upper GI bleeds. And they used certain statistical terms like adjusted incidence. Well, they adjusted the incidence rate on the multiple factors that could influence upper GI bleeds other than anticoagulation and cotherapy with PPI. So that would be age and history of, or other demographics, sex, and race. So they put a lot of factors into this, multiple, and created an adjusted incidence. And risk difference. I know we all learned attributable risk way back when we took step 1. So it is now often called risk difference. They've changed the term. And so if you're familiar with risk difference, with attributable risk, it's about basically taking out the incidence in the unexposed population from the exposed population. So you have a bunch of people who have upper GI bleeds. You take out the ones that didn't take the cotherapy. You subtract that from the incidence rate, which gives us a better idea of what the actual effect of the cotherapy is. And then all the values were measured per 10,000 person years, which means that it was over a span of 4 years, but not everybody was seen for 4 years. So some were seen for 30 days, 90 days, however long that time period was, it's multiplied by the number of persons involved. And so that gives you a better idea rather than just multiplying the number of persons or number of years. It's a better idea of how much data was collected on these people. And incident ratios is another term that I wasn't familiar with. Again, step 1 called it relative risk, and now newer studies are referring to it as incidence rate ratios, which basically is the incidence rate based on whatever factor we're looking at over or divided by the total population. So with that said, we'll go more into what was done. This 1.5 million, a little bit over that number of patients, ended up having over 1.5 million episodes of, or they call it episodes or windows of anticoagulation treatment. And this cohort analyzed that. The mean age of people in the study was 76 years old, and over half of those people in time years again were women, about 56%. And the majority, about 74.9% of those episodes were attributable or indicated by atrial fibrillation. And the episodes mean anticoagulation treatment, right? Okay. This slide goes into the first set of results, but before I do that, I just want to talk about the different current findings. Before this study, it was already understood that warfarin as an agent for anticoagulation was as effective. Well, warfarin was effective, but it was found that the 10A inhibitors like rivaroxaban and apixaban and dabigatran had equivalent efficacy in anticoagulation, and it was oral and didn't require much follow-up. And due to those findings, now, unless otherwise indicated, the oral anticoagulants, not warfarin, are preferred. That's per the USPSTF or the AHA. But in this study, they did use warfarin, maybe to overall how that affects the results in terms of PPI therapy with for people on warfarin, but also some people have to be on warfarin. It's contraindicated in certain cases, and for example, coverage, even insurance coverage. But for that reason, warfarin was definitely included for comparison. And then other things, only these three anticoagulants, which are the studied ones that are approved for anticoagulation for atrial fibrillation, were included in the study. Okay, so let's go to this first graph. So they checked out people who needed to be on anticoagulation, and they studied those who are on a proton pump inhibitor or not. The orange dots represent the ones that did not have the cotherapy with PPI, and the blue dots, navy blue dots, represent the ones who did. So going back to our understanding of statistical analysis, they have the little confidence intervals, and none of those overlap, showing a sign of statistical significance. Means the data that we're collecting here is valid. The next point to put out there is what's the difference between the two dots, the orange dot and the blue dot, for each different type of anticoagulants. So if you see the apixaban dots, for example, the data points show that there's a slight difference between having PPIs and not having PPIs on. It's a slight difference, but there is significantly more hospitalizations for people not on cotherapy with PPIs. And that goes across the board for all the anticoagulants. If you were on a PPI, you had less incidence of hospitalizations for upper GI bleeds. And then you look at the individual anticoagulants and the differences. So it seems that apixaban had a relatively low incidence rate overall, cotherapy or not, but say rivaroxaban has overall a high incidence rate of hospitalizations. And then on top of that, there's a further gap between the cotherapy and non-cotherapy groups. And the biggest difference, I guess here, the bigger trend, a huge difference. It seems cotherapy makes a huge difference for this set of data. And then looking at warfarin all by itself at the end, where it lies on the anticoagulation scale, it's surprisingly shown to have less upper GI bleeding rate overall than rivaroxaban. And but it still does have quite a significant difference between having a PPI on board or not. And so you might be wondering, oh, we use rivaroxaban now we do recommend it, and why is that having a higher rate of upper GI bleeds than, say, warfarin? And part of the explanation that we have is that, not from the study, but in other studies, is that it's long lasting, and its peak effect is at a higher concentration than, say, the other agents. And so that being said, and the risk being pretty high, it turns out that rivaroxaban does have a higher rate. But that was before the study and known. But that's what's showing. So to summarize these results, basically, rivaroxaban has the worst outcomes in general of all the anticoagulants, and cotherapy with PPI is the best for all of these anticoagulants in terms of reducing upper GI bleed incidence. And apixaban seems to have the best overall result, the lowest rates of hospital incidence, and works well with the PPI as well. Okay, and then I'll go on to these next three graphs. So they used something called the GI bleeding risk score, which I don't know if any of y'all have heard of it before. Oh, I see a quick question. Are apixaban and dabigatran different when compared on PPI? The confidence intervals seem to overlap. Okay, going back to that one. Compared on PPIs. So let's see. You're asking Dr. Hyan if they're on PPIs and comparing apixaban and dabigatran. So, I mean, yes, between the 2 points, when they're both on PPI cotherapy, they seem to overlap in that point, yes. But we did not necessarily make final conclusions on whether to, with co-therapy of PPI, to choose apixaban over dabigatran on this particular study. But overall, it was shown that apixaban, which I'll show you in the next categories, it fleshes it out a little bit, so maybe that'll answer the question better. So give me a moment while I go to the next slide. So this next slide talks about, excuse me, this next slide divides all these people into different groups based on GI bleeding risk. It's called a GI bleeding risk score, and I'm pretty sure none of y'all are familiar with that, and that's because this is a scoring system that this study came up with specifically for this study. And they did this because the most common bleeding score that we use out there and is established as a standard is the HAS-BLED scoring system. However, the HAS-BLED scoring system doesn't really target upper GI bleeds. It's just all GI bleeds as one category out of everything. And so they wanted to include all covariates and really highlight upper GI bleeds. And they came up with this scoring system that runs from 0 to 20, where 0 includes the lowest 5 percentile risk of upper GI bleeds in the population that was studied, and 19 represents the highest 5 percentile risk, or the 5th percentile risk of upper GI bleeds. So they scored people and divided them into these 3 categories of less than 10, 10 to 14 were in the middle, and then more than 15 on the higher end of risk. And when you look at that, again, it's hard to compare people on PPIs across the board and to compare the different agents because, like Dr. Hyan mentioned, they do overlap, but it's more of PPI therapy versus non-therapy. And even with dividing everyone out into these groups, it's across the board understood that PPI therapy, co-therapy with anticoagulants reduces the incidence, the risk incidence rate of hospitalizations for upper GI bleeds. And again, we aren't able to make definitive, statistically significant conclusions on which agent is better because, like Dr. Hyan mentioned, they do overlap in that, on those confidence intervals. Okay. So I definitely talked about the incidence rates. I just wrote it out here for if you wanted more numbers to look at. But let's talk about incidence rate ratios. So the 1.97 is, for example, for apixaban. That compares the difference of being on apixaban and not being on cotherapy and the general incidence rate. So these are the general incidence rates. And then, so apixaban was significantly lower than dabigatran and warfarin. And then, but when you compared with PPI cotherapy, the lower overall rate is incident risk ratio is 0.66. And then when you compared these incident rate ratios are even lower than the without the PPI cotherapy. So overall, the conclusions that they could make, I mean, they did go as far as saying apixaban had the lowest rate of upper GI bleed incidence of people on oral anticoagulants, and rivaroxaban had the highest. And then overall, PPI cotherapy was shown to have across the board lower the incidence rate. And we could not make the conclusions about which particular agent to use, besides the fact that rivaroxaban and apixaban, as you saw, did not cross over in their confidence intervals, and that's why they can solidly say that much in terms of anticoagulation. But choosing between dabigatran and apixaban, I think you need more data, and yes, definitely need more data. There were a couple limitations to the study, particularly certain parameters that they allowed or did not allow. In their inclusion criteria, they did include NSAID use in this study. So if you were on NSAIDs or added on and took NSAIDs at some point in the study, that was a covariate that they used to calculate the GI bleeding risk score. But it was not necessarily classified if there wasn't a prescription written for it. So whatever prescriptions were written, that's what was included. And if the patient happened to report that they took an NSAID or an aspirin or something like that outside of their written prescriptions, if it's over the counter, then maybe they could follow, but that part could have been missed more because NSAIDs are used very commonly. And then, and if NSAIDs were used, there's the PPI effect that it has is definitely underestimated because it's counting for the increased risk of the NSAIDs that weren't necessarily reported and the anticoagulation combined usage. And then some confounding unmeasured factors. So although they counted for so many various covariates, including age, race, sex, history of previous bleeds and all that, aspirin exposure and H. pylori infection was not. And so that's another component of it. And overall, it's hard to use a GI bleeding risk score that isn't applied to other standards. It's not used in the clinical practice. And those values, those rates only apply to this study, which is 1 million something people, but it's hard to make sure that transfers over to another population. It's not generalized or standardized. So that is going to limit kind of the universality of the study. Okay, so to kind of highlight what we currently talk about in our AFP guidelines about anticoagulation, I kind of mentioned it before. We've come to the conclusion that compared with vitamin K antagonists, which is warfarin, direct oral anticoagulation tend to have fewer overall drug-drug interactions and a comparable lower bleeding rate. But if you notice, definitely rivaroxaban has a higher rate than warfarin does, according to the study as well, and previous studies. A shorter half-life, and a fixed dosing based on indication, drugs, hepatic function. And then another thing that the AFP guidelines mention is you start an anticoagulation once this person has a VAS score greater than 1 to prevent stroke in atrial fibrillation patients. This is corroborated by the AHA, the ACC, and the HRS. So these are understood. And now we know we have reversal agents for rivaroxaban and apixaban as well, especially if they have life-threatening uncontrolled bleeding. So all of this is already in the standard of care and followed, but it does not address the high risk of upper GI bleeds in patients on anticoagulation, namely because there hasn't been enough data out there to study the effect. And I see why the AFP put this into the POEMS study or POEMS list this past year, because a lot of times I know I practice in the clinic and I see patients on warfarin or any anticoagulation. I don't immediately think of, oh, are they on a PPI? I do think of the HASLS scoring system, and if they have a high risk, it's something to be considered. If they're continuing to have episodes on the current agent, yes, think about switching over to something else with the lower risk. But I never really thought of PPIs as a major component, as being a cotherapy, them working side by side for these patients to reduce their overall hospitalization and definitely reduce their risk of GI bleeds. And because this is a limited study, because PPIs, I mean, in the past couple of years, we've had recalls for PPIs, and we are not necessarily using it on the regular for even GERD. We're avoiding it or tapering patients off of it, and then to consider using it for these patients who are probably going to be indefinitely on anticoagulation. These are the concerns. These are things that have not been addressed or quite studied thoroughly enough yet, in that this particular study was 4.5, 5 years long. So it requires more time to study that, like a lifetime of anticoagulation therapy and how cotherapy with PPIs would affect. At the same time, even though all this hesitance is there, and we can't necessarily apply it as a standard across the board, everybody with anticoagulation needs PPIs, I think I personally am going to start considering, should they be on PPIs? At least doing the HASLS score gives you an idea of their risk of general bleeding, and maybe that's a good way to start thinking about, should I have them on concurrent PPIs? Unfortunately, we don't have standards yet, but I think starting to formulate that, and then maybe in the next few years, getting more research and data in on how to go about that for people on indefinite anticoagulation therapy would definitely help. I also looked into the AHA, ACC, HRS guidelines. Only thing that really contributed to this subject was AFib management in general. And in that 26-page document of the current 2019 guidelines, they mentioned bleeding and risk about 61 times, but when cardiologists even aren't making an established reference to PPIs, it means there isn't enough information, because they don't mention PPIs or proton pump inhibitors, any form of that anywhere in that document. And knowing how high the risk of bleeding with anticoagulation is, it's surprising, but it's not, because we need more information before we can make those final recommendations, and yet to come. And oh yes, as for our USPSTF guidelines, it didn't say much at all. There was really only one point that we were considering for screening atrial fibrillation with ECGs. And of course, they we're saying there's insufficient evidence to assess the risks or benefits for screening right now. And it didn't really address, of course, PPIs at all. But that just goes to show that we have a lot of room to advance anticoagulation management, cotherapy with PPIs to be considered. So I've referenced the Ray et al. Study itself in the JAMA 2008 publication, and also the AFP Anticoagulation Guidelines. All right, any questions or comments? I see some chat. Oh, that's from Nicole, okay.
If anybody has any questions, you are more than welcome to unmute yourself or put it in the chat box there for Dr. Jose.
Excellent presentation, Dr. Jose. I appreciate it, and I'll keep it in mind when I'm taking care of my patients who have atrial fibrillation and oral anticoagulants. A good insight and something that will probably change the way I practice. Thank you.
You're very welcome.
Do we have any other questions? Okay, well, I think with that, we can conclude the meeting, and I want to thank you, Dr. Jose, for presenting for us today, and thank you for everyone who attended.
Very glad to join, and thank you all.
Thanks, Seena.